Hi, good evening, everyone. I would like to welcome you all to the latest Troubleshooters web series by Aspire titled The Art of Counseling in ART. We will be having a live discussion and an interactive session designed to explore key aspects of counseling in infertility care. We have three experts who will be discussing this issue with us. Ms. Sharon Lim, counselor from Fertility Connects Singapore. Ms. Helen Nicholson, fertility counselor from IVF Australia. And Associate Prof. Sonia Gerdeke, Associate Professor from Auckland University of Technology, New Zealand. So if for all the participants, you have any questions, please type it out in the Q&A chat box and I will assist you to get your questions answered. Okay, so without further ado, let's begin with our interactive session. Everyone ready? Okay, that's great. Okay, so let's go on to the first question. This is for all the experts. Can you all briefly discuss your professional background and training in fertility counseling? This is for all those people who want to do this in future or learn how to be counselors. So it will be quite a good and a great guide for all of them. So maybe Associate Professor Sonia, you can start first.
Thank you so much for that question, and thank you so much for having me today. So I came into this whole field in that I originally qualified as a clinical psychologist, worked for a while as a clinical psychologist, mainly in child and adolescent mental health, then moved on to women's health issues, and then went back and did a PhD in experiences of embryo donation of both donors and recipients in New Zealand, and moved more into fertility counselling. And alongside that, I also took on an academic role at the university. So in addition to that, I also regularly undertake a lot of professional development through the Australian and New Zealand Infertility Counsellors Association. So ongoing professional development in infertility and the psychosocial aspects. And then I share my role between academia and fertility counselling.
Thank you. How about Miss Helen?
Hi, everyone. I came via a social work qualification. So I did a 4 years honours degree in social work in New Zealand quite some time ago now. And then my career pathway has been through women's health and reproductive health as kind of a special interest area. So I worked in hospital setting in women's health, and then with adolescent and community sexual health education, and then I kind of segued into the fertility sector and have been working as a fertility counsellor for about 20 years now. Yeah, both in New Zealand and now in Australia. Yeah.
How about Miss Lim?
So I came from a healthcare background, both as a clinical provider, but also spent some time in the pharmaceutical business world. And eventually moved into counselling because at the time, it was a nice meeting point that kind of met my professional interest, plus my personal and family needs at the time, and also some personal experience. So I went off and funded myself through a Master of Counselling degree and started practicing. And of course, the Master in Counselling is only a starting point. So you know, over the years, and I've been doing this for about 10 years now, there are always additional courses to do, additional education to do. I actually very early on did a specific course in fertility counselling and worked with IVF clinics. So that's where the deeper interest has come about. Also, as you know, Sonia and Helen have kind of mentioned, it's important to network throughout all this time. So I am a member of UNZICA as well, the Australian New Zealand Infertility Counsellors Association. And, you know, it's important to try and take every opportunity to study, learn new things, but also to network with other professionals in the field across all disciplines.
Thank you. So I guess there are quite a number of ways that we can be a counsellor. So there are a lot of associations out there which we all can, participants here, audience can connect to learn how to be a counsellor too. All right. So coming to the next question, which is for me is quite important, is like how is counseling structured and integrated into the fertility treatment services at your own respective clinics? Probably Miss Sharon can start first.
So I'm not employed or attached to a particular clinic, but I and our group Fertility Connects works across several private sector IVF clinics in Singapore. So because in Singapore we're probably the only group of counselors that are members of ANZICA. And so we are the preferred counseling partner, I suppose, for some of these clinics. So it's almost a freelance or light contractual basis. We get called on to do the mandatory pre-donor IVF counseling. We do elective egg freezing counseling. And then the rest of the work from the clinic is really on an ad hoc basis. If the doctors or nurses at the clinic feel that they have a couple or a patient who's under particular stress or finding the fertility journey particularly difficult, as their preferred provider, they'd give one of us a call. And then we would see that client in private separately to the clinic.
See, thank you.
Yeah.
How about Miss Helen, in your setup?
As you said, I work for IVF Australia, and we're part of Virtus Health, which is quite a big organisation, and they have clinics now all across Australia and in the wider region. So in New South Wales alone, I'm part of a team of 10 counsellors. So we're employed. I'm full-time. I work full-time at the clinic, and we are fortunate enough to have an organisation that really values counselling. So we provide the necessary counselling for third-party reproductive arrangements, the donor arrangements, surrogacy, that kind of thing. But we're also providing support counselling for clients as and when they need through treatment. So we don't have a capped service. Yeah, I feel like that's really valuable. It's a really valuable part of the provision of fertility care that we're able to provide.
Yes, I agree. How about Professor Sonia?
I think Australia in that way is very privileged. In New Zealand, we've also got counselling that's available in clinics, but we have a very small number of counsellors. I think across the whole country, across all our clinics, Helen, correct me if I'm wrong, there are probably only about 12 to 15 counsellors, if that. Across all the clinics. So what happens in New Zealand and in Australia, if clinics want to be service providers and want to be accredited, they have to be accredited by a committee called the Reproductive Technology Accreditation Committee that's set up by the Fertility Society of Australia and New Zealand. And for a clinic to be able to comply with the code of practice set by that committee, they have to meet certain conditions. And one of those is that counselling services must be on offer in all clinics for them to be accredited, and that those services have to be provided by counsellors that are registered with ANZICA, with the Australian and New Zealand Infertility Counsellors Association. And ANZICA has got certain requirements for counsellors that they have to fulfill in order to be able to register to become ANZICA registered. And then once that's all in place, ANZICA professional standards of practice apply and guidelines. So the counselling is on offer in the clinics. I think sometimes you ask about how it's integrated. I think sometimes it would be great if it was more promoted to patients. It's usually available sort of 1 or 2 counselling sessions per IVF cycle, but it's variable as to whether those are funded or not. So quite different from what Helen's talking about. Here it's more people can access the counselling, but they probably have to pay for it through the clinics. And then the other bit that's really important to mention is that with donor conception, any donor conception that occurs through the clinics, the RTEC requirements stipulate that donors and recipients have to have a minimum of 2 counselling sessions before they proceed with donor conception. And if it's a known donor-recipient relationship, then there's got to be a 3rd session, which is a joint session that goes through implications counselling with them.
See, well, I guess it's similar in Malaysia too. So if you want Some centers have RTAC, so we have to have counselors on board too. Yeah. So thank you very much. And the next question is, what proportion of your counseling work is proactive, which is before a patient's requested, versus reactive in response to a problem or crisis? Hey, Miss Helen, you can start.
I think probably, I was chatting to my manager about this. I think that we're probably about 40% proactive and 60% responsive, because we get referrals through from embryology if things haven't gone well at a pickup. For example, if there've been no eggs collected or there's been no fertilization, we get referrals from the nurses. If there's been a miscarriage, or if someone's got, anxious when they're coming in, even pre starting their injections. So we get a lot of referrals coming through the multidisciplinary team as well as doctors, and then we get some people who ask to speak to a counsellor prior to starting because maybe they've got anxiety about what might be ahead. So yeah, I'd say probably 40% proactive, 60% reactive.
How about Professor Sonia, in your practice?
Yes, somewhat similar. I think the difference for me is because I'm largely in private practice and work outside of the clinics, I do get a lot of people coming sort of longer term. So once they've had their treatment, especially if it's been donor conception treatment, and they might come back afterwards, and it would be parents asking for help with sharing the donor conception background with their children, or it could be help with linking with people connected to them through donation. So it might be donor consent people and mediating a relationship with the donor or with same donor siblings. Sometimes I'll get requests that quite unusual, so quite longer term, where there might be a donor that's deceased and the family of the donor has found out, and they want to process that information and also process the fact that they have what they consider to be grandchildren out there, for example, if it's the parents. So there's a lot of longer term work. So not just sort of going into the start of the fertility journey, but also the longer term follow up, the implications that come up for people. And also some of my work is around, sometimes that infertility journey doesn't end with a pregnancy. It's often a lifelong journey for people, and further issues come up. So it might be that they've become parents and they are struggling with the adjustment to parenthood, sometimes feeling quite guilty about finding it stressful because everybody expects them to be really happy because they've had a child. Or it might be someone coming during pregnancy because they're really anxious after going through an IVF journey. So a bit of a mix of everything, really, which reflects how broad this field is.
Yes, definitely. Yes. How about Miss Sharon?
So I'd say very few of my referrals come direct from clinics. I think we work with currently one clinic in Singapore that tells their clients that, there is counseling support available for you before you start ART if you want. But cost is an issue. So the client, adds to their bill. So cost in Singapore of counseling combined with, shall I say, not much knowledge about counseling, or even a stigma like in certain parts of Asia, actually means that our client base from the hospitals and clinics, both private and public, are very small. Clients proactively find us through word of mouth, or honestly, some marketing that we do on Facebook or Instagram. Sometimes, like Sonia's patients that are clients that she's mentioned, I will get contacted by women or couples who may be further along on the ART journey and finding challenges, or even if they've been successful in bringing home a baby. It's not an easy transition, to have spent years trying to get pregnant and then suddenly having a baby at home. And that can be quite challenging in itself as well. So there are some clients, if they have private medical insurance or if they can afford a counseling service, will then come and touch base with us again. And then other new clients will come through other channels.
Yes, thank you. I think it's similar in Malaysia too. We do have counselors on board that basically is for the donation cases, but patients generally do not want to go to a counselor because of the additional cost. As it is, it's out of pocket costing. Charges. So that will escalate the cost for the entire treatment. So hence, they rather not go for any additional things. So that and eventually doctors themselves or the nurses in the clinic itself become counselors and to calm the patient down and things like that. Okay, so thank you. So the next question is, Ms. Sharon, if you could redesign fertility counseling from the ground up, what would it look like?
Wow. So in an ideal world, it would be wonderful if we could access people, in my view, at a minimum between the ages of 20 to 60, both men and women. So,
Okay.
but if I look at women alone, let's say first, I think it would be wonderful to start educating young people on fertility health. And there has been research across Asia as well for couples who want to start their families, couples who meet challenges, and we know that's at least 1 in 6 couples. On average in Singapore, they wait 6 to 7 years before ending up in an IVF clinic for investigation, by which time the woman might be 38, 39, 40 years old. So I think there's a lot of work as a professional group we could do up front, but that's difficult. Because this is Aspire, if I just kind of focus down onto IVF, okay, this is really what we're talking about here. Ideally, it would be great for a couple to have some coaching before starting IVF. So people come to the IVF clinic with a lot of information that they've Googled or talked about, and there are a lot of misconceptions and fears, or even unmanaged expectations. So in my experience, I found it very reassuring and helpful to couples to have a session before starting IVF, and they tend to then start the IVF with a little bit more confidence and calm. There are other points which are very, very stressful. So before FET, ideally a session, at least one counseling session before starting IVF, and one before every embryo transfer. Because a lot of the research indicates that the embryo transfer emotionally is the most difficult 2 weeks for a woman. And then there's the beta HCG blood test, right? And if it goes well, great. If it doesn't go well, it's absolutely devastating. And then how does a couple pick itself up and then come back and try again? So there's another potential point for intervention or engagement. And then I think we've already mentioned about some couples actually having challenges during pregnancy or even after the birth of the baby. So many points for engagement, but I would say at a minimum, a coaching or counseling session before the IVF even begins. And then before every, or at least the first few embryo transfer sessions, and then an opportunity when the beta HCG blood test is reported back.
Yes, I quite agree with you. I think the 2 weeks, the 2 week wait for the beta HCG results is like waiting for your exam, results to come out, and that's the most anxious moment in a patient's journey. Yeah. So moving on to the next question, Professor Sonia, is there a need to train more culturally competent fertility counselors across the region? If yes, what should the training focus on?
I'm going to answer this one with a big yes. So I really believe we should have more funding for counselling. It should be more integrated into our care. We don't just need more culturally competent counsellors, we just need more counsellors overall. So many places don't have counsellors or very minimal resourcing for counselling, or they're underfunded. Sometimes I feel also undervalued. And I think, we really need to stress the importance of what fertility counselling brings to our clinics and to the field. And if you look at the research, fertility counsellors are important not just because we can improve patient care and well-being, but also because such a substantial body of research now suggests that the vast majority of patients who disengage or withdraw from treatment before their medical specialists advise them to do so because it's so emotionally challenging and so stressful. And for people to actually to be able to persist with treatment, counselling can really make a substantial difference. So our success rates would also improve if we had more counsellors that we could train. So we need to normalise counselling, we need to promote it in clinics. And if we're training them, what should it focus on? Well, I think we'd need to have comprehensive training on all the psychosocial issues that infertility brings with it, that experience of infertility, things we've already been talking about today, those emotional challenges, the psychological challenges. We need to look at cultural views of what makes a family, of infertility, of the different assisted reproductive technologies, because that really shapes people's experiences and whether or not they engage with some of the treatment as well. We also need to look at improving people's knowledge and giving them training in donor conception and surrogacy, all the third-party assisted reproductive technologies. And training would have to include quite a lot of information on some of the implications of these third-party technologies for people, not just for the people that are using them, for the parents trying to build their families, but we also need to consider the implications for donors, because there can be long-term implications for them and their families. We sometimes neglect the fact that donors might have partners and children that are impacted by this as well. We need to think about the recipients and the fact that their parents and their families might be affected. And then most importantly, we need train our counsellors in implications of donor conception for donor conceived people, so that they really get a good understanding of what this means what it means to be donor conceived, some of the longer term impact, and for all the different parties involved. And then I think training should also cover all the different roles that we as counsellors can take on. I think when I first started counselling, I didn't realise how complex this area could be. But it's not just about supportive counselling. We do implications counselling, decision-making counselling. There's an element of therapeutic counselling where we're working with people with substantial issues, often around grief and loss. There could be relationship mediation or outreach. So if we're starting to do donor conception, linking between donors and donor conceived people and families, same donor siblings, there's a lot of relationship issues that we have to confront there as well. So the training is really quite comprehensive in terms of grief and loss, supportive counselling, implications, family work, and then probably also how to work as part of a multidisciplinary team. Because that can be quite challenging to negotiate that. And because it is a stressful field, it would also involve ways of promoting self-care and working in what's a challenging environment.
Yes, thank you. Another thing is about culturally that this Asia Pacific region is huge. So certain things are allowed in certain areas, certain things are stigmatized and not allowed, like third-party reproduction, not allowed in certain places. So and certain religious, sensitivities, we have to look into that too during the training. Okay, thank you. So the next question will be for Miss Helen. In your view, what makes fertility counselling different from other forms of medical or psychological counselling?
Well, I think that Sonia's actually covered what the specific kind of specialised knowledge is. So, I think that there's some similarities with other medical or psychological, medical or psychological counselling, but there is this particular set of specialised knowledge which is important for people to be able to do the work thoroughly and well. I suppose the overlaps are, the grief and loss work, counselling people around managing uncertainty and decisional conflict within a relationship, for instance. So, those relational issues. But again, there's this kind of specific area, particularly in regard to the third-party arrangements with donor and surrogacy, where it's quite a unique set of circumstances when people are planning families and the possible implications, because it's affecting potential future generations. Yeah, so I kind of think that the ethical considerations might be a bit different than in some other areas of medical counselling, but yeah, I think Sonia answered the question really well. I don't really have anything more to add at this point. Yeah.
Yeah, I think you've just got to keep so up to date in this field
Yes.
because things
Yes.
change so quickly.
So quickly, yes,
The
exactly.
legal framework changes, the policy framework, that you've got to be keeping up to date with legal changes.
Yeah.
Yes. Okay, going on to the next one, Ms. Sharon. How would you minimize chance of someone having unrealistic expectation? Know that you come into IVF is 100% success rate, and when you fail, then it's devastating for the poor patient. So how would you face this kind of scenario?
So, honestly, I believe that the doctor is a really key person here. So, couples will come, as I said, they've Googled, they've talked to other people, all kinds of expectations. Could be very overly positive ones, could be overly negative ones. They might come with statistics. So that conversation or those conversations where a doctor can take all the statistics, all that information, and make it just about that couple, I think is very important. Right. It's going to be very different for a couple where the woman is 40 versus 30 and has some other issue going on. So that very personalized information sharing and counseling is so important. And like anything else, repetition, speaking slowly, no jargon, making sure that your patient has understood what you've said, even making them repeat it back to you, chunking it up. So you don't want to sit there. None of us want to sit there and say, this is you, and not stop talking for 15 minutes and okay, got it, bye, see you, decide if you want to do this or not. So it has to be really broken down into almost 3-minute chunks and say, is that okay? Did you understand what I just said? Before you move on. But honesty is so important. Honesty delivered in a kind way. And giving, the opportunity for people to reflect back what they've heard. So I think it's kind of common sense, but sometimes in a busy clinic, or if we're a little bit scared ourselves about how to manage someone's expectations, the message might not get across. So I'd say consider who you're talking to.
Yes.
Is this couple's first IVF? Is it their 5th IVF? How much loss and grief have they already gone through before they come in and see you? In Singapore, they wait an average of 6 to 8 years. What have they even gone through before they come and consider their first IVF? So really personalizing the message, being as honest as possible, but delivered with some hope and as a partner, and then the common sense things about simple language, repetition, speaking slowly and clearly, getting an interpreter in our part of the world if you need to.
Yeah.
Yeah.
I guess.
How about you, Miss Helen?
Yeah, I guess the thing that I would add is because I'm thinking about being in the room with clients, and sometimes I think the specialists have done a very good job with provision of information, and it might also appear on a clinic's website. There might be good, accurate information promoted through social media. There might be good written information and handouts. I think sometimes what people want to hear is different than what they're told. And I also think very much about the power of the 5%, where people are told that maybe they've only got a 5% chance of conceiving, but that is an extremely powerful 5%, and it acts as a huge motivating factor for people to kind of chase it. So I think that hope really plays a big part, and desire for a family, and sometimes that hope kind of takes over the logical or rational kind information that people have had. So it's working with them around, bringing them back to what were you told, and what is your understanding of the information. So that kind of exploratory stuff. Acknowledging the hope and I guess overall reminding people that IVF it's not a silver bullet, but people come into treatment thinking it's going to be a silver bullet, and they'll leave with a baby. So it's complicated because of the hope that people hold. Yeah.
Yes, thank you. Yeah. So I got another issue about this entire thing about expectation is about also the consent taking, informed consent about exactly what you're going to go through and what you're going to expect. So, Professor Sonia, what would you think will be truly informed consent given the complexity of all the outcomes, options which are there in ART?
It follows on nicely from what Sharon and Helen have been saying. Our patients come in often quite emotionally distressed. They're processing a lot. The emotional complexity of what they're going through, the medical terms. We're so used to these medical terms that they're second language to ourselves and very new for the patients with whom we're working. So they're processing medical information, sometimes legal and ethical issues as well. So we need to be very mindful of cognitive overload, that there's a lot that patients are trying to process. So I like Sharon's phrasing there. We need to chunk things up. And to extend on that, I think we need to give patients time and space to really digest the decisions that they need to make if we want them to give informed consent. And like Helen said, refer them to different resources. We might need to give information in lots of different formats. It might need to be verbal as well as written, refer them to websites so that they can really kind of grasp and get to grips with some of the information that they have to process before they make a decision for informed consent. I think the other really important thing to be quite mindful of is power dynamics. So sometimes patients with medical specialists find it quite difficult to question or challenge their doctors even sometimes. So it's kind of working alongside them there to make sure that they're really having all their questions answered and any of their uncertainties explored. Sometimes that might mean that we'd invite a patient to bring in a support person with them. Maybe it's a community support person or a family member. But again, there, we have to be mindful of the fact that sometimes if you're bringing someone in from the community or a family member, that there's always the possibility of reproductive coercion, that there might be someone from your community that's pressurizing you into a certain decision, or a partner. So informed consent is actually quite complex because you've got to be mindful of these power dynamics between possibly patient and doctor, patient and family, patient and partner. So I guess as part of that informed consent process, you're providing as a counsellor a bit of a sounding board. You might be doing some psychoeducation, giving them space to reflect on their decisions. And if it's something like third-party technologies, really doing thorough implications counselling and going through that, all the different what-if scenarios with them so that they can really explore all the different options and what could possibly happen in the future to be able to think through that before they give their consent. And then I think equally important is sometimes we think of informed consent as a one-off process. People have made a decision, they've given their consent for something, and you proceed. But I think with so many of the areas that we work in our field, there are times when that consent has to be revisited. So it has to be updated. So for example, if you're asking patients before they go through IVF what they might do with their embryos, if they have some left over after they've completed their families, most of the time, couples, when they're going into IVF, their goal is to get to those precious embryos. They're not thinking, oh, I might have some left over once I've completed my family. That seems like a very long-term goal. So if you ask them at that point, what would you do with them? And arguably say, well, would you donate them to other couples? Or would you donate them to research? Or would you discard them? The decision they make then can be vastly different from the decision that they might make later down the track, especially, say, if they've had children through IVF and they've still got embryos remaining from the same batch that those children were born from. people's views of what those embryos mean to them can change dramatically, and some people might see them as children, which really can influence the way in which they elect to dispose of the remaining embryos. So revisiting consent can be really important.
Yes, thank you. The other part about, we've been talking only about the lady, and she giving consent, and a lot of times husbands don't really say much. So Miss Sharon, question to you will be, what approaches have worked best for engaging the male partners or even family members in cultures where the woman carries the burden of infertility?
So this is such an important point. And, I've had men telling me that when they go to an IVF clinic, they just feel like the sperm donor.
Yes.
Yeah, it's true. The couple walks in and people go, "Oh, hello, Jane." And then they look at the husband and go, "Oh, hello." And I've seen that happen myself. So perhaps in Asian societies, it's women do sometimes get blamed for infertility, but I think generally speaking nowadays, men also feel the burden. It's just that we don't acknowledge it quite so openly as we do with women, because maybe it's because women are more willing to talk to someone else about it. So I think it's very important for us as a group to acknowledge that men who travel on that fertility journey with their partner also feel a burden. It might be expressed or felt differently, but it's still felt. So I think your question was, how do we engage the men? I'd love to hear what Helen and Sonia have to say, but in my experience, it's direct or indirect. Indirectly, if I saw the woman alone, ideally I'd love to see the couple as a couple at least once. But let's say I only get to see the female partner. There's actually quite a lot that a woman can share with her female partner that she learns from a healthcare professional or from a fertility counselor. So in my case, for example, this idea that they're partners on a fertility journey, and hopefully they have an aligned goal, which is to bring home a healthy live child. And men, I think it's safer for them, I found, to first go towards the sperm quality question, because they're having to provide the sperm for the IVF. So I've had female clients who go home and said, "Hey, I've spoken to Sharon, or I've spoken to the doctor, and you know what? You need to get your sperm whipped into shape before we do the IVF." And the men will kind of respond to that. And then I leave the door open for the man to contact me informally if he has any more questions. And if necessary, I hope to engage more that way. If I have the opportunity to engage directly with the male partner, it's useful to just acknowledge his burden and just say, how has it been for you so far? How has it been? And oftentimes I've found that the men actually can feel either quite a big financial burden if they're having to pay for the IVF and they are the main breadwinner, which is often the case in Asia, or they feel a little bit helpless. They feel a little bit guilty that their partners are the ones being injected and having to go through the procedures. And they feel a little bit helpless about how to help. The other thing that men share with me is that they fear, before the IVF even starts, they fear the emotional side effects of hormones, because they've also heard all kinds of things. So those are little topics that, I would explore and try and reveal and give the male partner a chance to talk about. The other thing which is very useful is when you get a couple and perhaps the women don't feel as supported as they'd like to be by their partners, is to actually ask the woman or coach the woman to be able to ask her partner for what she needs. Because I think that when the men know, they feel less frightened and less helpless. they know, okay, this is something I can actually do to be a real partner to my wife on this fertility journey. So directly, indirectly, there are certain topics that men initially feel a bit more comfortable to talk to first, which are usually around sperm health or the medical issues or lifestyle. And then kind of getting to the nub of, what is bothering you, what is burdening you, and how can you be a more supportive partner for your wife? Because I know you want to be in most cases. But I'd love to know what Helen's and Sonia's experience has been.
Yes, so Miss Helen and Miss Helen, how would you get the men or family members involved?
I think certainly similar to Sharon, kind of talking about that the fertility uncertainty is a couple problem. It doesn't sit just with one or the person or the other. The solution is via the couple, and it's, as you say, usually a shared goal. So I suppose I think sometimes I work with clients where there really is maybe the part of a community where there is quite a taboo, or there are still quite conservative kind of beliefs or myths maintained about whose responsibility fertility is, and that when that rests with a woman. So sometimes exploring those myths, and also working with a couple if they're part of a family where maybe older generations hold those views, but they themselves don't, working with them about kind of the choices that they're going to make about educating their family about fertility treatment and who's where the diagnosis sits and what's involved, or if they choose actually to not engage with those conversations if they find them distressing, and work out another way that they can support each other through the process. So yeah, I think it can be very complex. I suppose sorry, yeah.
Sorry, you're finishing?
Yeah,
I just got another thing to add over there is that what if you have a situation where the both couples come in and then something bad happens and poor outcome, and then they'll ask you a question: is it the egg problem or the sperm problem? So basically, the couple is trying to seek and see who is to be blamed, the man or the woman. So how would you all, handle the situation?
Well, as a counsellor, I say that I'm not in a position to be able to comment on a clinical matter, and so I'd really be talking with them from a counselling perspective, which is, why are you asking this question? What does it mean? What does it mean for you? And what does it mean for any planning that you might be thinking about going forward? And what would be the purpose of establishing blame? Yeah. So it would be working with that.
Sorry, Sonia, but
no,
in that kind of situation, so men, when they find out that the infertility of that couple is mainly a male issue, it can be for some men incredibly devastating, right? Guilt, shame, all the rest of it. Oftentimes, if the couples are strong together, aligned, they work their way through it. They remember that they're partners in this shared goal. I guess worst case scenario, a husband might feel ashamed, helpless, less of a man, and the woman might be very angry because she's having to do IVF to solve the problem. And again, I think it goes back to what Helen was saying, is to work through the issues, see if we can get that couple to align on their goals and remember that they are a team again with a shared goal, regardless of what the cause of the infertility is. Sonia, I don't know if you have anything to add to that.
Sounds good to me. Yeah.
So then there's another issue about what if the doctor and the counselor have different opinions about how the patient should be managed and what to say or what not to say. How would you handle that situation?
Oh, crikey, that's an interesting question.
If it's a medical issue, then again, like Helen said, I'm the counsellor. That's not my role to comment on that.
Okay. And then there's another question here.
Navdeep, I suppose I'm thinking sometimes I can encounter a desire in myself that I would be hoping that perhaps a doctor might suggest to someone that it is time to finish. If they've done 16 cycles of IVF and the last 5 cycles they haven't collected any eggs, for example. And that can be a real burden. The momentum of IVF can create a real burden on a couple. But it's not my place to suggest that that's what should happen. It might just be a hope that I hold internally. But I think that, for the clinical decisions rest with the clinicians.
Yeah, I absolutely agree with that. However, sometimes it's worth exploring why there's this misunderstanding's the wrong word, but if there's some kind of chasm there, perhaps one way to approach it might be through helping clients make decisions. Making decisions that's best for them, and what other information do they need from their doctor to get more alignment. And there's always the possibility of a second opinion as well, if it's appropriate. And sometimes patients, because of that power dynamic, or they may have very strong loyalty to a certain doctor, may be reluctant or haven't thought about getting information from another place before taking the next step or next decision that's required. But I think I agree, as counselors, we are not doctors. It's not up to us to make clinical decisions.
Our role is to support our patients to explore the options. It wouldn't be to make decisions for them, but to go through the different options with them and consider the implications of each of those.
Yeah.
I guess also, like doctors and counselors, like we all work in a team. The nurses and doctors, immunology, we all work in a team.
Yeah.
So I guess if any one of us have a different opinion how to manage, I think it's professional that we all get into the office and discuss the matter out. So at least we face the patient with the same front, with the same story about how we want to manage. So I think that'll be a better thing rather than everyone says a different story, and that will confuse the patients even more. And there's some issues too about counseling sessions. Even pre IVF counseling sometimes can be never ending for counselors. Even for doctors, we face it too, where some patients ask the same questions but in a different way. Okay, so how would you handle this, and how would you stop the counseling session and move on to the next part of the treatment for the patient? Prof. Sonia, probably you can answer this question.
Helen and Sharon are better placed for that one in terms of clinical practice. If you want to take that. Yeah. Okay.
Miss Sharon or Miss Helen, any one of you?
I'll go first, and then I'm sure Helen will add. In my experience, when a client keeps revisiting something over and over and over again, it could be many things. It could be regret from the past that they haven't let go of. It could be fear about taking the next step, fear of failure or a lack of trust in what they're hearing. So it's really down to teasing out what the block is, and it's a kind of a block. It could be cognitive, it could be emotional, it could be social, it could be financial, it could be all of those things. But oftentimes, I would say, I don't know if you agree, Helen, oftentimes it's something about grief and loss and a fear about moving on and taking the next step.
Yeah, I would 100% agree with that, Sharon. I think if someone's stuck and they keep revisiting, there's something else that requires, and that's the benefit of having the counselling available, isn't it?
Right.
So, because then if you've got the time and the space to be able to kind of ask some questions so that you can, that time to explore and like the deep listening, right? And what is
Yeah.
what is the client really
What's
saying?
actually happening. And you know, I think it's good for the audience to understand that counseling is clinical. You know, the counseling skills that we bring into a session are clinical skills, and we do try and diagnose. You know, we sometimes it's trial and error, but what Helen and I are just talking about is trying to make a diagnosis. You know, is this grief? Is this loss? Is this regret? Is it anxiety? Is it fear? And then trying to work with the client to get unstuck. You know, so our tools are not drugs, but our tools are many things that I can't cover in this session, where it's trial and error. We try and get people unstuck or more courageous or willing to take a risk or make a decision.
Yeah.
Or go back to their doctor to ask the right questions.
Yes, and continue the count. So the doctor will continue the counseling and answer all the other questions. Yeah. And yeah, sometimes it can be, you know, especially with Google, Chat GPT, all sorts of things. So patients tend to quote from those things. So that will make the counseling session, explanation session a bit longer. So we'll be like, doctors will be like firefighters trying to, you know, clear all their misconceptions and myths sometimes.
So I have a useful phrase I use for that particular example, actually, Dr. Navdeep, which is, yes, all the statistics that we read about on Google and on papers, good and bad papers, they're population statistics. You know, and then I'll try and explain what a population statistic is. But what matters is you two sitting right in front of us right here, right now. And you can't translate all the statistics just to this couple sitting in front of the doctor.
Yeah.
So and sometimes that kind of opens up the conversation a little bit and kind of say, oh, wait, okay. You know, what's the detail? What is the detail that the doctor's seeing in us, you know, that's driving his decisions?
Yeah. Thank you. I got another question here for Miss Helen. It's wonderful that there is no cap on the level of contact or numbers of counseling sessions that people can access in your clinic. Do you have any advice on how this model of care could be argued in other clinics or countries, ideally to improve mental health outcomes for our patients?
Well, I think that Sonia actually referenced this earlier, because there is research to say that supporting people with their you know, through treatment, providing a service which is looking after their mental health as well as their physical health, and it enables clients to build resilience and stay with treatment, to stay with something that they want very much, to ease the journey and try and release the pain points. So I think that it's really important that that counselling is valued, because when people feel that they've got some tools and they've got a place that they can come and express themselves and they're heard with no judgment and they're supported, it can really help with the process of treatment.
It's resilience, isn't it, Helen, and compliance, better compliance. So this research I mentioned about, you know, couples taking an average of 6 to 8 years to, depending which country you're in, to see an IVF specialist, that was actually a really interesting piece of research, which is a little bit less formal than most, and it was an internet survey across Asia Pacific, well, Southeast Asia, actually. And it, you know, and internet surveys I think are interesting. Sonia, I'd love to know what you hear, but I think in couples who are in a position of isolation or shame, you know, being able to answer a survey in the privacy of your own home can be quite revealing. And one of the key findings in this survey, which I found incredible, was the question was, what was your reason for stopping IVF? And I thought it would be financial. And actually, no, number one, and this is an informal piece of research, number one was the emotional burden.
Yes.
Number one. A lot of couples stopped after one cycle because I think the quote was, it was so much more emotionally difficult than I thought it was going to be.
I think the
Why we
emotional,
absolutely need more counsellors and more
Yeah.
funding for counsellors.
definitely.
Yeah.
Yeah, so I think, like the role that we play with the ART clinics, I feel, is that we help couples to be more resilient.
But how about the other way around? How about the what practices that you all as counselors make you all more resilient and prevent burnout? So a lot of emotional burden also goes onto the counselors. So how do you all be resilient? Professor, would you like to answer the question?
You're very right. I mean, it is a tough job to be a counsellor. You're often listening to people who have very emotional, difficult stories to share. They're coming to you in times of distress. So I think that can be something that affects you personally. And I think just like we try and provide space for our patients, we need to do the same for ourselves and acknowledge for ourselves that this can be difficult, that we need space to process our information, that it's okay to feel sad, to remind ourselves that it's not actually our job to find a solution for the people we work with, but to walk alongside them. But then it's really important that we have a place where we can process what it's like to do this job. So I can't overemphasize how important it is to have a good supervisor that you can go and debrief with and offload what you've been hearing and doing in your counselling work, to have a strong peer network. That's where Nzika has been fantastic, and hopefully we're setting something similar up through Aspire. So if I've got something difficult that I've been processing with a client or a patient, I've got a whole number of peers throughout Australia, New Zealand, and the Asia Pacific that I can give a call and we can debrief, and I can get a bit of support as needed. Of course, it's as important as in all professions that we do good self-care, look after ourselves, get exercise, nutrition, set limits, etc. And I guess the other important thing in building resilience is constantly engaging in professional development. Just keep learning, keep finding out more about this really complex area of fertility counselling that we're involved in, so that we can build up our skills and therefore build up our resilience as well. And know when to take a break. You've got to know what your limits are. And sometimes you do need to take a bit of a step back because it is an emotionally intense job. And I think equally important is, in addition to that professional development and having a professional network, supervision, peer mentors, is trying to make sure you've got an organization that has a supportive culture, where you're working as part of a multidisciplinary team, where you all realize that this is an emotionally intense job and you can be there for each other.
Yeah, and I think it's only going to get more complicated as other technologies and things come along. I think that new technologies, new treatments create more need for professional development, bigger, or more diverse kind of ethical questions come. So I think it's only going to get more complex as time goes by, not only for us to understand, but for clients in terms of their decision making around and access to different kind of up and coming add-ons and technology. So
to consumer DNA testing, the whole can of worms.
Well, things like DNA, genetics, AI, all these things will complicate the methods even more. Yes.
It can be very overwhelming. I mean, one of the, everything that Sonia and Helena said are so important, especially, the bit about having colleagues who understand, that you can debrief with and get support from, or even advice from, because sometimes you can doubt yourself, whether you've done the right thing. But one thing personally, I also add to that whole list that I've brought from previous professions that I've had, is to remind myself that even though we work in an incredibly emotional field or a very intense field, medicine and nursing would be the same. We are professionals. And sometimes the limits of what we do, I think sometimes we have to remind ourselves that we can't solve the world's problems.
Yes.
We really can't, and we shouldn't feel like we have to. You have to actively remind yourself of that. But what we're trying to do is help the person in front of us in that moment. And sometimes if I consciously tell myself that, it helps. It helps.
Our job isn't to fix, it's to walk alongside.
Correct.
And be supportive.
Absolutely. That's beautifully put. Yeah.
Okay. Well, you know what? It's been 1 hour that we've been talking and discussing about this issue.
Wow.
I think 1 hour is definitely not justified. You need a longer session, probably a kind of 2-day masterclass on counseling sessions. And I think I learned quite a lot. I'm quite sure the participants here also learned quite a lot. And well, there are a lot of challenges that we're going to face as fertility doctors and professionals and staff. So with that, I thank you all, thank the panelists, I thank all the participants for joining in the talk today.